Hey, everybody, it's Kevin and Donna, and this is the
Mhm.
Deprescribing Show. We're so glad you guys are here with us. Donna threw one at me that I've actually haven't encountered personally. So it was very interesting. If you think edema, if you think my patient has some swelling, do you think of a nerve pain agent right away? I didn't, but Donna does, and she'll tell us more about that right after this reel. Donna, how are you? What's been new? And I have my bracelets about ready to give out. And I've got my
Yeah.
MedStrong book ready, personally signed by the Donna Bartlett on the inside. So I feel very blessed and excited on that side.
So I was so glad I got those out to you. So enjoy the read, Kevin. Enjoy the read.
I will. I'll be sharing the love, all you folks that are out there. It's near and dear to my geriatric heart, so that's a wonderful deal there, Donna. I'm super excited and always excited to support and connect with you on those kinds of things.
Absolutely.
Yeah.
So lots of interesting things in regards to I'm back at the hospital with my students, and man, are we just seeing so many incredible cases. And doing some outreach programs too with the students, and just, gosh, slicing and dicing these meds that are just so inappropriate and unnecessary. It's amazing to me the number of meds people are on that just are not necessary at all. Incredible.
It's wild, Donna, and I loved the other day I put out a post there that got a little bit of attention with the invisible pharmacist, right?
Mhm.
And your commentary just related to only seeing what was it, 4 patients and pulling off 12 meds or something along there. I mean, it's
Yes.
wild,
Yep.
just how our system thinks that we have to stick with status quo and decrease costs, and they're looking for all these solutions when there's a really incredible advocate for patient safety being those individuals that focus on and prioritize deprescribing meds and optimizing, ultimately what those meds are doing. So
And the
huge help.
eyes that pop when with the patients, that when you're talking to them and you're asking questions, or you're saying, "Do you experience blah blah," some certain side effects, and they're just like, "Oh my gosh, all of them." It's like, well, it could be this med. So, which, I mean, I'm laughing, but it's not even funny. It's like, yeah, it's I'm not surprised. So, yeah, so a lot that we can do for sure.
It's so interesting because my wife and I, Savannah and I, were talking about all the things that we buy and purchase, in our life. And we usually prioritize before you purchase, you look at reviews and you ask friends and you get references on these things you're purchasing. And then as you use them, you're quickly commenting with all the folks that you're around on how well it's doing or how poorly these purchases are doing. A TV, for example, like, hey, picture quality is great, have trouble connecting with devices, et cetera, et cetera. Like everybody in the family knows that, right? With the new TV that Donna's purchased. But when it comes to drugs,
Yeah.
not at all. We just think my doctor's prescribed it. I'm just going to take it, or I'm not going to take it. And I'll forget it. And then we have consequences on both ends, without putting too much emphasis. And this case that we're going to bring up here, Donna, that's one of yours, is
Yeah.
is one of those to me that's really connects the dots with
Yeah.
something is wrong here. Maybe we
Right.
should take meds.
Yeah. It's eye popping too. When the students and we review these cases, and it's, we're just like, oh my gosh, as we review each of the medications. So, yeah, so
Wow.
we're going to talk about gabapentin and severe edema. And this is just so important to have people understand that this really is a problem. I think over time we're able to get gabapentin to be dosed appropriately for renal function, because that was a big issue even just, I don't know, a few years back, maybe 5 7 years back. We saw a lot of gabapentin being over prescribed, and that the doses were just way too high for the renal function of the
Yeah.
patient. So, and I think that that was quite a learning curve that I see is often reduced without even intervention from pharmacy. So I just see that happening regularly, that gabapentin doses are actually being dosed renally responsive, shall we say, that we're being renally responsible for the doses that are being actually prescribed or changed at the hospital. So I love that. And I think that that's great. Don't know how it is everywhere, but that is something I've seen. And I feel that, okay, education is happening and people are paying attention to this. So great. But we can click forward to this case and we can just see that, gabapentin, the other thing that we're learning and seeing more of, and it has been in the literature for probably a good 20 years, I'm going to say, Kevin, is the edema associated with gabapentin.
Yeah.
And so here we have this gentleman who
The one thing I wanted to touch on just with like the history of gabapentin, such an interesting drug just in general. How we're going from something that's going to be used for a seizure disorder and then is pulled over into the neuropathic pain space very heavily, especially with a diabetic neuropathy. And the interesting piece that you mentioned with the renal based dosing is I remember early on when it was really taking steam, the problem wasn't related to the lack of dosing. Like it wasn't related to having problems with dosing it renally. It was the lack of dosing. Like we weren't increasing doses appropriately to be able to get to therapeutic gain, right? And so that was the early worry of gabapentin in general. Then we started to see more issues with respiratory depression or other breathing disorders related to it. And then when I was a hospital pharmacist, I noted one time that we had a diversion issue related to gabapentin. And I thought, this is so strange. What's going on here? And now today, there are articles out there based on, is gabapentin one of the more dangerous drugs in the United States?
Absolutely.
So
Yeah.
anyway, not
And
a,
there's studies out there too, Kevin, like you're talking about the respiratory depression. And I even say it in the book, what should not be combined with. And what they found is that 900 milligrams or more of gabapentin can actually increase that respiratory depression when it is added to other products such as opioids and benzodiazepines. So it's not even a lot of gabapentin, really, if you think about it, but that 900 milligrams really puts people on the more dangerous side, if you will, for increased risk of respiratory depression.
Awesome. Here's our patient TR.
Yeah. So what's so important here is that he actually is being dosed somewhat appropriately. Like if you looked at pure renal function, he
Yeah.
might be okay to be at 600 milligrams 4 times daily. However, he is an older adult, so he's in his mid 70s, and he is taking 600 milligrams 4 times a day. When we look at dosing older adults with gabapentin, it should be no more than 3 times a day. So 4 times a day is more so for younger adults, if you will.
Right.
So once we get into the older adult range, we really don't want to see 4 times a day. We'd much rather see the 3 times a day instead. So right away, we're like thinking, okay, we don't really like that he's 4 times a day. But then on top of this, so we're looking at this, right? 2,400 milligrams, like, ooh, that's a pretty hefty dose of gabapentin. And we see this extreme swelling and weeping of the legs. Like it's horrific. And this poor person is now unable to walk. For over the last 6 months, he's been more or less bound to a wheelchair. So,
Give me the timeline, Donna. Can you give that to the audience? Like, when did the gabapentin start? When did the doses kind of go up? All that.
Yeah. So starting in earlier this year, things started to ramp up with the gabapentin. So January, and then increase until probably around like Aprilish, May, and then so now, like May to now, he has chronic edema according to the records, and I'm like, oh, this is pretty interesting. So and then the other thing that I think is really interesting is we're doubled up on opioids and doubled up on muscle relaxants. So it's like, whoa, what is going on here? Like, we're not even effectively treating pain. We're just keeping on trying, And if you're so swollen and that much edema, gosh, how uncomfortable. I don't know if any medicine would like actually help with that pure discomfort.
Oh yeah.
So anyways, we're just like very concerned for this patient, thinking about anticholinergic burden too. And so muscle relaxants are 3 themselves, and now we have 2, that's 6. Anything 3 or more for the anticholinergic burden is an issue for a lot of things, but one thing is falling as well.
Yep.
So, this poor man is unable to walk. He's fallen in the past. It's just not a good combination. So, this
Wow.
is just his meds for pain. If we move on to the next slide, we're going to see all of his other meds that he's taking. And you can see on the left-hand side that there's an abundance of meds. I didn't put in all the strengths and everything else here. I just listed because I just wanted to share the story
Yep.
and share the information that's provided. I think what's more important is what's over to the right-hand side in the blue box and the problems that were stated. So, this chronic edema, general weakness, and gabapentin can actually cause general weakness too, infer the weakness, especially in lower extremities. But he's also on muscle relaxants too. So again, I always say to my patients, it doesn't just relax the one muscle that's twitching or that's giving you trouble. It's every single muscle it's going to be relaxing. So, what's been going on there. He has iron deficiency and anemia. Spinal stenosis seems to be a major problem that he has, and the reason why he's one of the reasons why he's on all of this pain medication too. It's pretty interesting what we found might work for him, though. I thought it was interesting at least, but we'll get to that. So over the past 6 months, he's not able to walk as much. He's more, he's basically sleeping in his recliner, 4+ bilateral edema, just all these things. So what was really interesting too is that his blood pressure went lower. And because of that, his metoprolol and furosemide were stopped. And amlodipine was added on, which was just like really strange. Don't quite know why that happened. It was on an outpatient visit that had happened. So it was part of the story of him coming in. So not only does he have chronic edema, but his edema has now gotten worse over the past month or so that these things had changed. So we're really, percolating here a problem for this patient. So looking at this, we see that his creatinine clearance has been slowly declining too. So just so many issues with him. So gabapentin we know is better to take 3 times a day. We wanted to at least start the reduction of this. Let's stop gabapentin, but we know that after chronic use, we might not be able to stop it right away or all at once. So just get them to 3 times a day at first, and then eventually keep lowering the gabapentin. So that was initiated, and then with his renal function, it declined slightly, but his renal function wasn't horrible. It was just on the decline. So,
Okay.
like I said before, like the 2,400 milligrams was really okay. If he was younger, you would be like, okay, he's still within his dosing range, but older adults were getting a little bit more concerned. So, and we're still thinking side effect, right? Side effect of the gabapentin. So looking at that a little bit more. We're concerned because we don't understand his pain. We don't know where he's at. There's not a lot of pain scale information. There's something from like maybe 5 or to 7 days prior that had a pain scale. But other than that, a lot of his pain relief was provided around the clock. So we didn't know how much pain or discomfort he was really in, just looking at his chart and trying to unravel what was going on. So we mentioned that to the docs about this, that, hey, we don't know what his pain scale is. These are being given around the clock. Don't know if anything's really helping or not. We really need to have some of that guidance to see what's working or what isn't working. And we asked for some discontinuation of the medicines. So that did happen where they stopped at least one of the muscle relaxants. The cyclobenzaprine was stopped, and plus it was given multiple times a day. So we were happy with that. That just having one med once a day might be a little bit nice of a drop in anticholinergic burden for him as well.
Awesome.
So much going on there, and trying to make some recommendations. So there's of course so many different interactions that are going on too. He does have this issues with heart failure. So really the metoprolol and furosemide are definitely necessary. Amlodipine, we asked to be stopped, and that was stopped as well. So even though he was on like a lower dose, we wanted to make certain that it just wasn't even a factor with this worsening edema. So trying to work with things on edema, ended up with tachycardia because the metoprolol had been stopped. So really trying to balance things out. So we're able to, make some adjustments for this patient slowly but surely. And it turns out that his edema was actually becoming lessened, and that we're able to get his heart rate down for him as well, and also reduce his anticholinergic burden.
Wow.
The other thing that was suggested is he was going to have some more evaluation done on the spinal stenosis to try to alleviate some of the pain. So we had mentioned that actually Botox injections are actually recommended and indicated for the spinal stenosis that he'd have, and he'd have a better response rate to that. Maybe could get him off of the pain relievers in general and just work with Botox. So kind of an exciting, that's not going to happen at the hospital, unfortunately, but at least it can move on to recommendations for this patient down the road. So
Donna, tell me this: when you saw, like you're saying, with the 2,400 milligrams, you're saying initially like there wasn't a massive concern based on the renal dosing, but with your experience, and I know a lot of studies that have popped out there, we're seeing more and more drugs start to show that they're not seeing benefit over this dosing, right?
Yeah.
And with gabapentin, I feel like it's been fairly widely publicized that 1,200 to 1,800 milligrams is usually like the top of the dosing, like pyramid.
Mm-hmm.
We're seeing benefits for pain control and analgesia, like types of effects.
Mm-hmm.
Is that a red flag already in your mind? Like when you see a dose over 1,800, it's like that we need to look at that.
When I see that it's being increased, and all these other pain relievers as well, I start going, okay, things aren't working here. So that to me is a red flag for sure. Definitely any high dose gabapentin, I want to know, like, is it working? Is it even efficacious for you as we're at these higher doses? I often see that my big concern, especially, is the falls associated with gabapentin,
Right.
that I see so often, and always trying to get that reduced or stopped as much as we possibly can. So yes, definitely a factor for me. In the next couple of slides, though, I want to show and give some parameters, if you will, that what I saw in regards to this edema. And so we know that, we're talking about like how rare this edema is with gabapentin, but I've been seeing it more and more, especially in our older adults. And we see it really often, unfortunately. And so we started talking about this, students and I, and we started looking up what are some of the issues. And we're finding that some of these studies, and they're not even new necessarily. There are some newer ones, but they were in younger people too, on just doses of 1,800 or more of gabapentin, and seeing edema in younger folks too. But what I think is really important is that there's some parameters around here, and this Cochrane database shows that the incidence of edema for older adults with gabapentin with 1,200 milligrams or more, that incident goes up to 7% in those patients. So I think that that's important. I think it's important that we know that older adults are more sensitive to this particular adverse effect. There's another study that goes back even further, and it showed even a higher percentage, and that's on the next one, of 7.5% with 1,800 milligrams or more. So the fact that I only, dropped this person's gabapentin down to 1,800 still concerns me for this patient. So we have to keep going on it. But it really shows that this is significant side effect, especially in our older adults.
Donna, I think, gosh, I can go one of two questions on these ones, but I'm going to go this way. When you're looking at somatic and nervous pain, like when you're evaluating pain and you're looking at the modalities that are in play, right? The one thing that I feel like happens, and you mentioned it, earlier in the slide deck, is that you have looks like a provider team that's trying to throw some darts related to what are we treating, how do we get a hold of it, and now there's multiple opiates on board, multiple muscle relaxants, and then the list continues to go on. When you're trying to help a patient with particularly understanding their pain modalities and then the treatment modalities that are appropriate, do you find that gabapentin is more often or less often prescribed for something that is not fitting of its particular mechanism of action?
Yeah. So I definitely think, especially in the higher doses, Kevin, like we're talking about, I think that is probably an inappropriate indication. Like the pain that they're trying to treat is not going to be alleviated with gabapentin. I have to say, the one thing that whenever I see gabapentin on someone's list and I'm speaking with them and doing like a face-to-face review, I always ask, does it help? And sometimes I'll get, I don't know. Like, do you ever experience pain anymore? And sometimes the answer is no. And I'm like, well, maybe you don't need it. And then other times people are like, oh my gosh, yes. Like if I forget it, I know I forgot to take it. And then I take it and that pain dissipates. I was like, okay, but they tend to be on a much lower dose too. So to me, I'm like, all right, then that makes sense. And I'm not going to say don't take it. It's going to increase your risk of falling, because pain is going to actually probably increase their risk of falling too, because they're not going to want to move as much. So, you kind of have your risk versus benefit. But when we see these high doses and, oh, it doesn't really help, or I don't think it's really helping, I needed other stuff, or I don't know, it's helping out on so many things. Those are when I start really questioning and thinking, maybe it isn't appropriate.
Love it. And the other one that I want to jump into real quickly is my favorite drug to bring up is always amlodipine. I don't know why, but it just is one that sticks in my head, because for me, it's hit me so many times that I went, oh boy, they just got put on from 5 to 10 milligrams of amlodipine. They're getting swelling. It can't be controlled. The furosemide's not working. So my curiosity here, Donna, when we're seeing more and more gabapentin-related edema issues, are there some other drugs that you'd like for patients listening, students, pharmacists listening to go, hey, here's some other ones to maybe think of or red alert in your mind could be a cause of that edema, and it's not just an exacerbation of their CHF?
So other than amlodipine and gabapentin?
Yeah, like those two to me, right, are ones that just kind of
big ones for me.
Yeah.
I like to think about like other comorbidities. So if somebody does have heart failure, I want to be thinking about what could be increasing that risk. So any kind of calcium channel blocker, I don't want to see that at all for someone with heart failure, for example. So I try to look at things like that, like what else is going on for the patient. So I think that's a big one for me. And then of course, renal function. And if anything comes up against the renal function that needs to be dosed appropriately for someone's renal function, I immediately want to get those reduced as much as possible. But I have to say, like, my biggest concerns are really this that I see all the time, amlodipine and gabapentin. Totally see that too often. There's other, like, there's so many things I want to talk about, but it's not in line necessarily 100% with edema. So it's other things that I'm thinking about are other side effects. So how about you, Kevin? Is there something that comes to mind for you other than those
I
two
think
major ones?
I think we just don't see it as often, or at least I don't, is pregabalin being used and
Oh,
still keeping the
totally.
edema,
Yes.
right? And then the exact same thing that we've seen with NSAIDs causing edema, kind of
Yes.
related to their
Absolutely.
interaction with other
Yes.
drugs in particular.
Yes.
Once again, other drugs I just don't see as often as I used to, but pioglitazone, rosiglitazone, those
Yeah.
guys.
All the ones that we don't want to see in heart failure either. So yeah,
Exactly.
all of it. Yeah, for
No,
sure. So
I think
you're right on with all of those, Kevin.
all of those. And the only other thing that just for folks to think about is when we have agents like gabapentin and amlodipine on board, you also have to be able to think of what is their excretion pathway. And then sometimes some of the issues that we're seeing popped up is because it's related to it's stopping how they're excreting. But we have a couple really good questions here, Donna, that I
Oh,
would love
great.
to get to before we say adios. All right. So here is one from Jim. He says, Donna, in your hospital, does a summary of charted changes, including updated indications, go to the primary care provider and the community pharmacy in the discharge package to ensure no one thinks this is an on oversight and tries to e-prescribe gabapentin?
Yeah. So definitely to the docs. But it's also handed to the patient too. And we are always, and I think a lot of hospitals do this too, but we have the, um, changes in medicine. So maybe what's added, what you're going to continue to take, and what's being stopped. So there are those sectioned out. And it could be that the changes are, oh, we're reducing the gabapentin. So I just had another one this week. They reduced them again from double the dose down to just a fraction of the dose. So that's often happening. Does it go to does that chart itself go to the pharmacy? I don't believe it does. I don't see any mechanism here that, because in our pharmacies we don't really see electronic health records, so I don't see that going other than a patient bringing in their information to a pharmacy and saying, again, we leave it up to the patients, and I don't agree with that either. But definitely it does get forwarded to the primary care, and the patient is always encouraged to bring this to their appointments.
Yep. Yeah, I think that you're
Gotta
really
be
highlighting
done.
something great. There's great intentions, right,
Yes.
related to, like, we try to document, we try to inform, but making sure that the entire team is informed, I think, is a real onus put back on us from a profession standpoint, and on top of like NCPDP when it comes to standards and guidelines, and some of you software vendors out there when it comes to the ability to absorb more clinical data inside of our systems. I did want to say Sylvia, one of our favorite patient advocates, also commented on here that she said, I agree with Donna. The question, does it help, is so key, and goes on to talk about some things that she's done for her patients, which I absolutely love.
Yeah. Yeah.
And then Jim just sent back, even getting a simple indication would help. And I can't agree more. I mean, sometimes in the hospital, Donna, you and I both wish that we would get a simple indication, when it started
Mhm.
off, so we don't have to go to every specialist and find out, why did the primary care doc keep it on, and what is it for? Well, I have no idea, but the specialist put it on, so I'm not touching it.
Yeah.
Um, those
Yeah.
issues always
Yes.
crop.
Yes. And now what I'm starting to do, and it's funny how this has evolved so much for me, but talking about some of these questions that we got, I will actually say, hey, you reduced this here. Thank you so much. Make certain it's reduced and at discharge. It remains reduced at discharge. Like, I actually write those notes now. And then some of the other things I'll do is say, this has been on the patient's med list, seems for a decade or something, if I
Yep.
have that information, and
Right.
can't find an indication, please reevaluate. And like, I just don't even know why some people are on it. So I do that, and I actually do those things now and talk to the students, like they're really trying to figure out these correlations.
Yeah, those communication pathways are so key for someone to actually have an opportunity to make a difference on a patient's chart. And I think sometimes upon discharge, we just assume so much, or we presume that the patient has so much autonomy, right, in their care decision making pathways, when that's really not the case. We all know that they're leaning on a lot of healthcare system elements that they don't have in their own control. And if they can't see their primary care doctor within the next 3 months,
Right.
what are we going to do for them? We're just going to leave something on that's problematic. Any leading or leaving notes, Donna, for everybody?
Yeah, I just think bring your questions. Thank you so much for those that are listening in and bringing their questions. But we need to just continue to educate. There's so much, and like I've said so many times over and over again and again, is that medications have worked. People are living longer, but we've got to be careful with them. We have to be thinking about the changing body and what is going on with these meds, and don't keep adding. Let's start optimizing and really making certain that people are taking only what's necessary.
Yeah, no, I can't agree more. It's so nice to be able to have these kind of conversations in the open and get some more dialogue coming out there, because they're not, our patients aren't that different. You guys have very similar patients to us. It's great to hear your guys' experiences and how those things are working out and the way that you're practicing. And Kimberly, thank you so much for your question there, and we'll answer that one offline. Everybody, have a wonderful rest of the day, and we will talk to you soon.
Thanks, everyone.